This is Angela Huttner, a co-host of the Communicable episode you're about to hear. We want you to know that this episode was recorded several weeks ago in what were still peace times for Lebanon. Professor Souha Kanj is still in Beirut, and we've been in touch with her these past few days. She's fine. She's working very hard to keep things working, to keep things moving forward. For example, as president of Lebanon's Society of Infectious Diseases and Clinical Microbiology, she decided to proceed with their national congress planned for end of September, though she had to put it online. The topic was infectious diseases during wars and disasters. She was heartened by the fact that some 1,300 participants joined from 50 countries around the world. I hope, she says, that I will be able to continue to focus on educational and academic activities to keep us distracted from the brutal war happening here. We thank Souha again for taking the time to do this episode with us. We're also well aware that this episode will be released on the 7th of October, a year to the day of the brutal attacks on Israel. We watch our friends and colleagues on both sides of this border as bombs now fall on both sides. I'm not religious, but I think I understood when Souha wrote me and asked, "Let us pray together for this nightmare to end soon." Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, an open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined today by my co-host, Thomas Tängdén, infectious disease doctor and clinical associate professor at Uppsala, Sweden, and fellow editor at CMI Comms. Thomas has authored many papers on AMR, as well as national and European treatment guidelines for MDR gram-negative bacteria. I'm so glad you're here, Thomas.
Hi, everyone.
So, this is the second installment of our Nightmare series, and the topic is carbapenem-resistant bacteria. We are delighted to have with us two guests today. The first is Professor David Paterson, a friend of the podcast. David is professor of medicine at the National University of Singapore. He's also honorary professor at the University of Queensland. He directs Advance ID, a clinical trials network comprising more than 40 hospitals across Asia, funded jointly by the Wellcome Trust and several Singaporean institutions, with an aim to conduct clinically important trials in the field of AMR. And he has had more than his fair share of carbapenem resistance exposure. David, welcome back to Communicable.
Thanks so much for having me, Angela.
Our second guest is Dr. Souha Kanj, professor of medicine, head of the infectious disease department, and chair of the infection control and prevention program at the American University of Beirut in Lebanon. She is also honorary professor at Radboud University in the Netherlands and president-elect of the International Society of Antimicrobial Chemotherapy, ISAC. Souha trained at Duke University, where she's established the infectious disease transplant services in 1994. She's been back on this side of the pond since 1998. Welcome, Souha.
Thank you, Thomas. Very happy to be with you today.
As our listeners know, we start with a get-to-know-you question for our guests and also our hosts. Today, I'm going to ask, what is your best way to forget about antimicrobial resistance for a while? I'll start. Mine is to just go running for a while to get some fresh air and some new perspectives on things. How about you, Angela?
So it kind of sounds crazy, but I would go into my pocket because in my pocket is my telephone. And in my telephone is a group chat with my siblings. I'm the sixth of six kids, and none of them, except my sister-in-law, are doctors. So in this chat that we, have chirping in our pockets all day long, there is very little talk of AMR. So that is a place where I can go, even like on long call days. It's just nice to have them all like in my pocket. Souha, what about you?
So I would say at work, when I'm not thinking AMR, I would be thinking about fungal infections. But when it's not related to medicine, two things I love to do is walk in the beautiful mountains of Lebanon, and we have many of these. And I love swimming laps. I try to swim twice per week, and during my long laps of swimming, I plan my week ahead.
And last but not least, David?
I'm in an all-boys book club, and it's great because there's people from all manners of the political spectrum, and we never agree with each other, just like we never agree, I loved this book or I hated this book. But I think it's something we should try to do to get out of our sort of echo chambers where we've all got the same opinion, just nod, yeah. But sometimes to be a bit confronted by other people's ideas, which I think is sometimes helpful to us.
Great advice. Yeah, unfortunately, the book club I recently belonged to died out, and we all felt the same way about everything. And maybe that's why it died out.
Yeah.
So thank you so much. So back to real life and to our nightmare of the day, carbapenemase producing bacteria. So we intentionally left this broad. These can be Enterobacter, Pseudomonas, and Acinetobacter. My first question is for David. Can you start us off with the Enterobacterals and with a very macro view? When did CRE first come onto the scene?
Yeah, it's been a really sort of interesting history. And I remember as a fellow that we had a patient with an ESBL producing Klebsiella. And this was like emergency. It was a big deal. And we had an outbreak in our ICU. We had an outbreak in our burns unit. And there were a number of publications already. And there was one very striking one from New York City where they replaced use of cephalosporins with carbapenems and saw that treatment outcomes for these ESBL producers was better. The number of ESBL producers was reduced. So this would have been, late 80s, early 90s, I guess this publication was. And of course, the more we use it in antibiotics, the quicker we lose it. And so it would be more than 20 years ago now that we started to see carbapenem-resistant organisms. Certainly the setup for them was someone who'd been in hospital for a prolonged period of time, particularly in ICU, sometimes in transplant units, that had a ton of antibiotics, typically including carbapenems. They were sick people, and then they came against this, monster, this carbapenem-resistant organism that was very difficult to treat. In fact, I remember when I was a transplant ID fellow in Pittsburgh, we started to use colistin, and I had never used colistin in my life. But this became a regular occurrence because of these sick people, typically in ICU, who probably had hospital-acquired organisms. That was very late 90s and then early 2000s. Really, it's the early 2000s that carbapenem-resistant Enterobacteriaceae started to really creep up and become noticed.
Amazing, because it's just so geographically variable, right? Thomas is from Sweden. I'm practicing in Switzerland. The 1990s, for us, it's still quite a rare sighting to see a carbapenemase producer today in 2024.
And when I visit hospitals in Asia, it's absolutely a universal problem having a carbapenem-resistant Enterobacteriaceae. It's an every day of the week occurrence.
So, Souha, as David points out, historically CRE has been nosocomial, but we're beginning to see transmission in the community with reports of healthy younger people contracting CRE infections, even though they were never near a hospital. Can you tell us where is this happening most? What microorganisms are involved? And which clinical syndromes are people presenting with?
Yes, Thomas, I would say really over the past 10 years or so, we started to see carbapenem-resistant Enterobacteriaceae in community settings. And I think there are definitely some countries that are reporting such infections from the community more than others. What comes to mind would be countries such as Russia, for example. Many countries in the Eastern Mediterranean area have reported community-acquired CRE infections. And also, as David mentioned, countries in Southeast Asia, they encounter not only hospital-acquired, but community-acquired CREs all the time. And in terms of which bacteria, these are typically your E. coli, Klebsiella pneumoniae, but also Enterobacter, Citrobacter, even bacteria from the class of Morganella, Providencia, and Proteus have been reported to cause CRE in some of these countries from community-acquired infections. And when we think about what syndromes or what types of infections present as community-acquired CRE infections, I can tell you from my practice, for example, it's not uncommon that I see patients coming with simple cystitis. Simple meaning no fever, no chills, just lower urinary tract symptoms. And the culture grows Klebsiella pneumoniae, that's CRE. In India, Pakistan, or other countries in Southeast Asia, countries that are under conflicts or after natural disasters, community-acquired pneumonia can be due to CRE, Klebsiella, KPC, or others. I would say perhaps UTI is the most common, followed by skin and soft tissue infections.
I might give a little experience. I was in India last week, and the topic came up was multidrug resistant typhoid fever. We think in high-income countries, typhoid fever is typically imported and rare, whereas in places like India, Pakistan, Bangladesh, huge numbers. And when we start to see this degree of resistance, it is big business. It's a really important and difficult challenge.
Yes. So on that note, David, I'm going to get into more technical things with you. The Ambler classification. So though it might seem painful, it really isn't. The Ambler classification helps us to understand carbapenemase and how to treat them. So can you remind our listeners of what it is, of how these classes came about, and which beta-lactamases are in which class?
Like everything, there are different ways to classify beta-lactamases. The Ambler classification, it's A, B, C, D. It doesn't talk at all about substrates or inhibitors, but is really all about the amino acid sequence. I think in 1964 or 65, the first plasmid-mediated beta-lactamase was detected. The patient had an E. coli UTI that was due to this plasmid-mediated beta-lactamase that knocked out amoxicillin. And so that simple beta-lactamase is one of the Ambler class A, but it doesn't affect third-generation cephalosporins or carbapenems. But then in the 1980s, when ESBLs came along, these are also class A. And we know there were sort of TEM ESBLs and also SHV ESBLs. And compared to their sort of simple TEM1 or SHV1 parent, they've now got an extended spectrum and they can destroy third-generation cephalosporins. Then similar structural point of view are the KPC type carbapenemases. So even though we call all of these Ambler class A, they have very different substrates. They have to some degree differences in inhibitors as well, but it's mainly the substrates. Then class B are the ones we really, really hate because these are different. They're metallo-beta-lactamases. We hate them because we don't have great inhibitors of them. So the classic one, of course, is NDM. There's also IMP and VIM. Now, class C is our AMP-C beta-lactamases. So Enterobacter cloacae has got that encoded on its chromosome. It's not a carbapenemase, but it knocks out third-generation cephalosporins quite nicely. We can also get the AMP-C beta-lactamase that's plasmid encoded, and E. coli can have that, for example. Even though I said the class Cs are not carbapenemases, you can get production of a ton of AMP-C, and then there be things like porin loss. So you remember with gram-negatives, we've got an outer membrane and an inner membrane. We've got to somehow get through that outer membrane. And if we have lost the porins, these channels getting through the outer membrane, it creates a tough life for antibiotics. And so we can see outer membrane protein loss plus AMP-C and have carbapenem resistance, even though we don't actually have a carbapenemase. And then class D are our OXAs. In Enterobacteriaceae, we've got things like OXA48, and then there's 181, and there's 232. The other thing we need to remember is that with Acinetobacter, one of the most frequent reasons why we have carbapenem resistance is production of OXA23 or OXA24. And these are very frequently found in carbapenem-resistant Acinetobacter. There are some other oxes as well, and you can even get oxes that don't destroy carbapenem antibiotics. I know a lot of people don't get beta-lactamases, even some ID people, because it's complicated. And part of the issue is all these ridiculous three-letter abbreviations, and they have different substrates and different inhibitors, and it's hard to keep a grasp on it. But let's go over it one final time. Class A carbapenemases, the most frequent one will be KPC. Class B are our metalloenzymes. Most frequent one will be NDM. Class C, not really a carbapenemase. Class D, we've got our OXA48 and its relatives in Enterobacteriaceae, and OXA23 and 24 in Acinetobacter. So that's the Ambler class and carbapenemases.
Thank you, David. That's a really clear, understandable explanation. And Angela, you started this question saying that the Ambler classification is not painful, but I sometimes get some reluctance when I teach people about this system. And I think that to get really clinicians to dig in, you need to explain to them why is this important. David, you mentioned that it's related to which enzyme inhibitor that will be useful. So we're actually not only treating a specific bacteria, but we are targeting the enzyme. So can you comment on that already now?
I think it's really important that we know how to treat these particular carbapenemase producing organisms. And for years, the backbone of the treatment has been use of a beta-lactamase inhibitor alongside a beta-lactam. I think it was in the 1970s that amoxicillin and clavulanic acid first came into being. Clavulanic acid, of course, being an inhibitor, and it inhibited beta-lactamase, which was destroying amoxicillin or ampicillin. Now, in terms of what inhibitors hit different carbapenemases, so avibactam, which comes in ceftazidime avibactam, approved in Europe now as trienam avibactam, avibactam will hit class A and class C, and also the OXA48s of class D. So therefore, ceftazidime avibactam would be a good antibiotic for KPC producers. It would also be a good antibiotic for OXA48 producers. Vaborbactam, there's meropenem vaborbactam, and relibactam will knock out your KPC, but will not inhibit other beta-lactamase classes. Now, what's coming up and new are some class B, so some metalloenzyme inhibitors. One that got into the New England Journal earlier this year, cefepime with taniborbactam. Taniborbactam actually inhibits A, B, C, and D. So that is pretty neat. It's interesting, though, it doesn't hit all of your Bs. So, for example, there's an IMP carbapenemase, which it doesn't inhibit. There's also the OXA23 and OXA24 of Acinetobacter, which it doesn't inhibit. You can sort of see that there are developments, and there are even pure metallo-beta-lactamase inhibitors getting into clinical development. Suha, I wonder, it's probably worth just talking about aztreonam avibactam for a second. Are you happy to walk us through the rationale for it as a combination?
Yeah, thank you, David. So the combination of ceftazidime, avibactam, plus aztreonam has been used for CREs that are from the metallo-beta-lactamase class, particularly the NDM. And there has been several studies, particularly from Italy, looking at the effect of this combination of ceftazidime, avibactam, plus aztreonam to treat such metallo-beta-lactamase. But really, what is the effective components from this combination is the avibactam-aztreonam, and therefore ceftazidime per se does not have a role to treat these metallo-beta-lactamase producers. However, since very recently, avibactam was only marketed in combination with ceftazidime. This was the go-to combination for treatment of such metallo-beta-lactamase producers. And none of the studies were randomized controlled studies. It was more of real-world evidence based on large case series, but really showing efficacy in the management of these, as David calls them, the monsters, because we don't have too many other choices to treat such carbapenemase-producing bacteria. Still, the drug is not available in many countries, but Aztreonam avibactam seems to be the promising drug that we should be considering for such pathogens. There is enough data published now to show that the combination of Aztreonam avibactam is effective, but also is safe. Now, obviously, we need to consider geographically what is the most common types of CRE that are present, and when do we have to consider an empirical option for MBL producers. I can give you the example of my own country, where at the beginning of 2000s, we had predominantly OXA48 producing CREs. And so as soon as we had ceftazidime avibactam available for us, it was the drug to go to for empirical coverage, whether a patient was previously colonized or had a transplantation or malignancy, because we didn't have the other beta-lactam, beta-lactamase inhibitors. We didn't have meropenem-vaborbactam. We didn't have imipenem-relebactam. And anyways, these two drugs, as David mentioned, are not drugs that would work on OXA48. Now, more recently, over the past 5 to 6 years, we've had a complete shift. And now the majority of the CREs we have, particularly in our hematology-oncology patients, in our critically ill patients, they have metallo-beta-lactamase producers. And so we've really depended heavily on ceftazidime avibactam with Aztreonam. I think one needs to consider the epidemiology of the country, the hospital, also the unit where we're practicing, to decide on what drug we should be using for empirical therapy. Targeted therapy decision is always easier because by then you have your susceptibility, you have your molecular data, and then you can focus your therapy based on these results.
If I could just expand on a couple of issues, and one is now we have the potential for our laboratories to tell us rapidly what carbapenemase is being produced by our bacteria. And so there's even some tests, for example, the BioFire test, which can be done directly on a respiratory tract sample, so an endotracheal aspirate or a bronchoalveolar lavage. While that is absolutely great, a little word of caution, now our bacteria are starting to break the rules. Not that they've ever obeyed rules, but just as Souha and I both said, ceftazidime avibactam, great for KPC, and so you might think, the rapid test telling us that there's a KPC there, we're safe to use ceftazidime avibactam. Now there are strains that, even though there's a KPC, have found ways to become resistant to ceftazidime avibactam. The same has happened with this new one, cefepime-teniborbactam, and there cefepime binds to PBP3 of E. coli. And what has the bacteria done? It has mutated and changed PBP3 so cefepime can't bind to it. And so therefore, even though you've got this great inhibition of a beta-lactamase, you can have other mechanisms of resistance. These bacteria, they just drive us nuts. They are so canny in terms of, we think we've got them all sorted with being able to inhibit beta-lactamases, and then they come up with all these other mechanisms of resistance as well, which creates a difficult life.
David, so at least for us, in addition to the in vitro susceptibility data, we've had available the Carba5 test that will give us the answer within a couple of hours. So combining the in vitro susceptibility with the Carba5, we feel more comfortable choosing the drugs for our CRE, particularly when we're dealing with our very critically ill patients.
Souha, can you just tell us, those of us who luckily don't yet have to deal with this level of carbapenemase producers, what is the Carba5? Tell us about this test.
So the Carba5 is a phenotypic test that gives you 5 different gene expression. If you have KPC, OXA48, VIM, IMP, or NDM. And so within really a short time, you can have the results from the laboratory. And then if your patient has a KPC producer, by in vitro testing, the Klebsiella is susceptible to ceftazidime avibactam, then you feel very comfortable that this is the drug to go to. If it's resistant to ceftazidime avibactam and the lab does not do the in vitro susceptibility combination to ceftazidime avibactam plus aztreonam, then if the Carba5 test gives you that it's an NDM, you feel comfortable using this combination. So I think by combining the in vitro susceptibility with this Carba5, different laboratories have different ways to test for these carbapenemases. Some laboratories use molecular tests. I think whichever test you can put your hand on, the more information, the better. One word of caution, as I always like to speak about stewardship, is sometimes by having these tests available, it does not convince people to differentiate between colonization versus true infection. So you see people jumping to use these broad spectrum antibiotics with every positive test.
Yeah, so that was going to be my next question for you. Does your hospital restrict the use of the Carba5s or impose a certain guidance, a stewardship guidance with it when you open those results? How do you deal with that? People panicking when they see a positive result, which may really just be a colonizer.
I'm actually very happy to say that we have a very strong stewardship program in our hospital. So any physician can request the Carba5. However, when it comes to the use of broad spectrum antibiotics, many of these are restricted, which means that you need to have either the infectious diseases team or the stewardship team approve that this is an indication for those broad spectrum antibiotics, particularly in low middle income countries that have a lot of financial difficulties. Sometimes the drugs available are limited, and so you want to make sure that the drugs are being used by patients who need them the most. So with a very rigorous stewardship program that rounds on these patients almost on a daily basis, we have the ability to discuss with the primary care provider and follow the patient very closely. We tell them, rest reassured, we're calling this colonization, but we're not leaving you and your patients. We're following their daily signs and symptoms and inflammatory markers, and that gives them the comfort that there is a specialist who's helping make the decision on these patients.
You know, often we come to discussions with our own perspectives from high-income countries where we have stewardship programs. I go to countries like Vietnam. They don't have aztreonam. I go to other countries in Southeast Asia, and in government hospitals, they can only order enough ceftazidime avibactam or aztreonam for 5 patients a month. When they're seeing 5 patients a week who might meet the criteria, this is a really horrible situation. In many parts of the world, polymyxins are still the go-to drugs for carbapenem-resistant organisms because of lack of access and availability to beta-lactam, beta-lactamase inhibitor combinations that many of us just take for granted.
If I may add, in some people's minds, whenever you have a carbapenem-resistant Enterobacteriaceae, we need to be jumping to the novel drugs and beta-lactam, beta-lactamase inhibitors. However, in rounds to the fellows around me, I always start by the question, what is the site of infection? How sick is the patient? Because there are still many of the older drugs that we can use to treat certain infections with CREs. For example, if I have a limited supply, let's say ceftazidime, avibactam, and aztreonam, I could be using quinolones. If the organism is susceptible, I could be using tigecycline if it's an intra-abdominal infection. For simple cystitis, I've seen a lot of patients coming to clinic with CRE, but they are still susceptible to nitrofurantoins, to fosfomycin, to trimethoprim sulfa. So these are scenarios where we could still depend on our older, cheaper drugs to treat. It really depends on how sick the patient is and what infection am I dealing with. Is it bacteremia, pneumonia in a critically ill patient, or other types of infection where I can really use some of the other more available drugs.
So I think we need to talk about combination therapy. So you mentioned, David, that the bacteria are breaking rules. They're producing several enzymes. They have efflux. They have porin loss. So in a way, we're also breaking rules when we use combinations. So they haven't been tested. But do you think in the future that there will be validated tests for susceptibility combinations that aren't available on the market in a fixed combination? Do you think that we will start using several enzyme inhibitors for the same patient because we have several enzymes in the pathogen?
Yeah, I think in places that can do it, we will be very much personalizing therapy. So there's in vitro synergy service. And imagine doing that and also being able to do TDM, therapeutic drug monitoring, for a whole range of antibiotics, including beta-lactams. Some people are getting very sophisticated at that. What we don't have yet are substantial, large trials that can prove that, as a general recommendation, even that combination therapy is better than monotherapy. And what we have to do is look to some really successful platform trials. So, for example, with Staphylococcus aureus, there is a massive platform trial that's recruited over 3,000 patients that is looking at all aspects of Staph aureus bacteremia. We need to get together as an ID community and do the same with serious gram-negative infections to come up with some good rules that we can give to our colleagues. When we see what is described as the real-world evidence, sometimes can actually be very poorly conducted observational studies that try and link outcomes to a certain drug despite all manner of confounders. So we need to really get some RCTs going.
I can add to that briefly. We are dealing with a lot of these very resistant Enterobacteriaceae, and sometimes when it is a bone marrow transplant patient with bacteremia, you get your susceptibility panel that is resistant to everything, and we've had many scenarios like this. The clinical microbiology lab will not do the synergistic test because the argument is always there are no CLSI, no UCAST criteria for interpretation. But we're in a way lucky that our experimental laboratory for pathology and laboratory medicine, we very often send them the isolates and ask for various combinations. Now, obviously, this is not validated. Not uncommonly, we get a CRE that's resistant to everything, including polymyxin. And as David said, bacteria can be very clever and you can have multiple mechanisms of resistance at the same time. We tell them test it for a series of these various combinations, and then we get a result back that it is susceptible to combination A plus B. It could be a rifampin plus tigecycline or whatever combination. And so we have depended on this to guide our therapy when we are in desperate situation. We did that with cystic fibrosis in the past when we had these very resistant Pseudomonas with no options to treat. We depended on some of these results. There are scenarios where we have a dying patient and we want to try everything possible, and these synergistic tests that have not been validated can help guiding us, and we've had some success stories.
Yeah. We've also done some synergy testing in my research lab for Swedish patients. We don't have that many, but for example, the aspirin and apibactam combination, since it was not an approved drug on the market, there were no susceptibility tests either. It's tricky, but I agree with you that it's better to have some in vitro data suggesting an effect than nothing. But it's not validated and we can't recommend it for others. David, we touched upon this a few times already, the geographical differences here. So there are different enzymes that are predominant in different geographical areas. And there's also some differences across clones when it comes to virulence and how pathogenic the bacteria are. Can you discuss a bit about that?
Yeah, absolutely. North America is still predominantly a KPC place. Certainly metalloenzymes, the class Bs, the NDMs, for example, they are being found in the United States, but overall KPC still dominates. The tricky thing for places like Europe is that now we have a mixture. We've had a lot of OXA48, we've had a bit of KPC, we've got some NDM and some VIMs, etc. And that is the most awkward situation. The worst situation would be a third of KPC, OXA48 and metallos, because then you can't really predict. Normally, if you go down to a really local level, meaning an ICU level, it should be pretty consistent what's around in that environment. In Asia, NDM is really predominant, but OXA48 is there in the mix, KPC less so. Although China has got KPC and it is a real mishmash. And in Australia, we've got IMP4, which is our own sort of metalloenzyme. So it's a tricky situation. Overall, my feeling is that there is going to be this mixture of a situation where you can't trust unless you test. And you can say, well, we're an OXA48 place, but then you get the NDMs and all the rules are off. Just talking about virulence and carbapenemase producing organisms. So one thing in Asia that is quite commonly seen are hypervirulent Klebsiella. And occasionally in Europe and the United States and Australia, patients are seen with these hypervirulent Klebsiella. So they have liver abscess, sometimes they have endophthalmitis, sometimes meningitis, really nasty Klebsiella infections. And luckily, historically, they've been very, very susceptible Klebsiella. But now we've started to see ESBL producing hypervirulent Klebsiella. And there are now reports, and it luckily is still just reports. It's not a uniform thing that there's even carbapenemase producing hypervirulent Klebsiella. It reminded me of in the US community-acquired or community-onset MRSA infections that also had PVL or some other nastiness. And that's what we're really fearful of in Asia, for example, that we'll get this frequent carbapenemase producer in a hypervirulent strain. That is not going to be a nice situation when you've got that mixture of resistance and virulence. It's one thing when we've got our ICU patient who's really sick from other stuff and they're colonized first and then they get an infection opportunistically. But what we really don't want is community onset nasty infections that are resistant.
Yes, so then if you happen to get this nasty and extremely resistant bacteria spreading in the community and you start seeing healthy people dying from these infections, that's when you start changing your empirical therapy to cover for these strains and you will have this vicious circle of antibiotic resistance. So, David, you wrote a piece for JAC Antimicrobial Resistance arguing that carbapenems should be used for all ceftriaxone-resistant Enterobacteriaceae. Do you still believe this? Do you worry about squeezing the balloon, creating more carbapenemase-resistant Enterobacteriaceae and Pseudomonas in hospital environments? How do you think we should handle the new enzyme inhibitor combinations versus carbapenems? Which one would you go to first when it comes to preventing emergence of resistance?
Everything's about context. And with some colleagues, we did the Merino trial. And our hypothesis in the Merino trial was that piperacillin tazobactam was just as good as carbapenems So we wanted to show that a carbapenem-sparing option was just as good as carbapenems. That was our hypothesis. And I do need to apologize to antibiotic stewardship programs the world over that our hypothesis was proven incorrect. There were some things that people have commented on, one of which was that we gave the piperacillin and Tängdén just as a 30-minute infusion. And maybe if you'd given it as a prolonged or continuous infusion, the outcomes with piperacillin and Tängdén may have been better. The other thing to remember with the Merino trial is it only looked at patients with bloodstream infection. And absolutely, if we've got an uncomplicated UTI, there's no way that you need a carbapenem. Even much more importantly, if you've got an ESBL producer just sitting in your respiratory tract or sitting in your urine and you're a catheterized patient, a person who doesn't actually have an infection, you don't need any antibiotics, let alone a carbapenem. So I'm really hopeful that there will be RCTs that show that there are carbapenem-sparing options for seriously ill patients. I do believe that carbapenems are our treatment of choice for certainly bloodstream infections with ESBL producers. I don't think they're the treatment of choice for some less serious infection types, but absolutely bring it on. Let's get some RCTs that can show that there are carbapenem-sparing options, because I think that's what we need.
So I think that's a very important question that people think about. When you have a strain where you could use both a carbapenem or one of the very newest drugs that we have, would you favor saving the newer drugs for later and go for the carbapenem, or vice versa?
Yeah, that's a really tricky philosophical dilemma. For example, you could say ceftazidime-avibactam is a great drug against ESBLs, which it is. Why don't we use it as a carbapenem sparer? But then I would say, look, that's our KPC in OXA48 and sometimes carbapenem-resistant Pseudomonas. So I would prefer that everything's got its place. And for me, carbapenems do have a place with serious infections due to ESBL producers. And let's find optimal place for each of our choices. Have a lot of things going on at the same time rather than just be fixated about one or two choices. One untoward consequence of our antibiotic stewardship programs is that it may have inadvertently led to decreased antibiotic development. So, for example, the newest antibiotic approved by the FDA, sulbactam, durlobactam, has had sales of less than $2 million per quarter since it was released. So in a year, they might get $10 million at the most of sales in the United States. While we think, well, that's a lot of money, in fact, because we have quite rightly pigeonholed that for carbapenem-resistant Acinetobacter when we really don't have many other options, that has meant that if I'm someone who wants to make money out of developing drugs, those antibiotic stewardship people are actually dampening down my profits. And I do think a side effect of that has been, because we've been so good, that drug companies, when they've got options of where to put their cash, have actually said, we're not going to put it into antibiotics because those people are so good at controlling antibiotic use that they're not going to make big profits. I don't think that should be stopping us doing our antibiotic stewardship activities. It's more, how do we find other ways to incentivize antibiotic development?
Yeah, and that's a big problem. But surely the solution can't be to use the new drugs more. I mean, it's about finding other ways of incentivizing the company. Yeah,
exactly.
Souha, you are head of your stewardship program, speaking of. What is your approach to prevention, to infection control? Once you have a case, what do you do?
Yeah, thank you, Angela. I give you an anecdote before I talk about infection control measures. For years, we've been struggling with Acinetobacter, extremely drug resistant, only susceptible to tigecycline and colistin. And we've tried with very strict infection control measures to control the Acinetobacter. And the only time we were able to succeed is when we combined the efforts of the stewardship program with the infection control program. we applied a carbapenem sparing strategy, which meant over 3 years, only patients who absolutely needed carbapenems were allowed to take carbapenems, and every other patients were switched to alternative therapy. We found that when we implemented the stewardship activity together with the infection control measures, we were able to bring down the multidrug resistant Acinetobacter in our units, and this work was published. In terms of infection control practices, for any patient who has a CRE infection, whether it's a colonization or it's an infection, these patients are placed on contact isolation, which means obviously hand hygiene has to be done as it is universal prior and post contact with patient or their environment. But also the healthcare workers have to wear the gloves and gowns whenever they're in the patient's room. Now, critical care units, we do have a very strict rule about screening everybody who is admitted to the critical care unit. We do screening for CRE, we do screening for XDR Acinetobacter, and now we've added the Candida auris because we've also had a huge problem with Candida auris since 2020. These patients are placed on contact isolation until we have the culture results. And then only those that are positive remain on contact isolation throughout their hospital stay. During outbreak situation, we do repeat the screening cultures on a weekly basis because over the past few years, we've had a lot of outbreaks of these multidrug resistant pathogens. This was very tough to deal with, particularly during the economic crisis that hit Lebanon very hard since 2020. And when we had drug shortage, not having the drugs available to us, we put even more efforts on infection control to try to prevent the spread of such pathogens.
Might just give a little bit of our experience as well. In a hospital where we didn't have many resistant organisms, suddenly we had this explosion of carbapenem-resistant Acinetobacter. And so our infection control team did a lot of environmental sampling. And then when that outbreak was eliminated, there was another one about 3 or 4 years later, and it was thought that this was imported. But someone did some metagenomics of the sinks, and they found that the exact same strain that had been there 4 years before was still present. And then there had to be plumbing intervention, which was big time. It was there all the time. But this concept of could we get to a waterless ICU is a really interesting one in terms of trying, because we do know that some of these wet places, like drains, can be a persistent source of resistant gram-negatives. So that's something down the line.
Yeah, we've had similar experience. We take a lot of environmental cultures and we do genotyping of these isolates. And we've had Acinetobacter cultured from keyboards, pillows, mattresses, ventilators. And so for our protocol nowadays, we do hydrogen peroxide, decontamination of rooms after the patients leave. We've also applied strict rules such as bare below elbows. So none of the people working in the ICU are supposed to wear any watches or jewelry. We have cameras in the ICUs to monitor hand hygiene. A lot of things have happened over the years, and I would say we've been luckily successful in controlling one outbreak after the other.
I think if hospitals have the resources to do whole genome sequencing to aid infection control of carbapenem-resistant organisms, I think it's actually quite useful. And sometimes you can actually get ahead of the game and find little clusters that you weren't even aware of.
Absolutely.
Turning now to treatment of Acinetobacter and Pseudomonas. Souha, David, are there differences in the principles of how you would approach these two other families as opposed to the Enterobacter?
These are two very common infections that we deal with in our hospital. Let me start with Pseudomonas. We have a very high rate of carbapenem-resistant Pseudomonas in my hospital. It can reach 20% of our Pseudomonas isolates. But also, we are dealing more and more with difficult to treat Pseudomonas, which means being resistant to all the class of penicillins, of cephalosporins, carbapenems, and quinolones. Now, luckily, we've had available in the country the beta-lactam, beta-lactamase inhibitors, ceftolozane, tazobactam, and ceftazidime-avibactam. Prior to the availability of these two, we were depending on polymyxins, with all the problems of polymyxins being not good drugs for the lungs, being highly toxic, and as in all the more recent guidelines, they advise against using polymyxins for treating such Pseudomonas. I would say in my hospital, we've really depended mostly on ceftolozane, tazobactam, and sometimes ceftazidime-avibactam. In the region, though, it's important to note that there are some countries that have reported a higher susceptibility to ceftazidime-avibactam as compared to ceftolozane, tazobactam. For example, a study published from Qatar showed that they had more resistance to ceftolozane, tazobactam as opposed to ceftazidime-avibactam. So again, there's a lot of regional variability, and at the end of the day, we really need to depend on in vitro susceptibility and whenever we have access to the molecular typing of resistance. Acinetobacter is a huge nightmare for us because I would say in a study that we conducted in ventilator-associated pneumonia from 2007 to 2017, Acinetobacter was the most common organism causing ventilator-associated pneumonia. And guess what? The only two drugs that we had available to us were tigecycline and colistin, both not being good drugs for pneumonia. So we were really using double dosing of tigecycline plus inhaled colistin. And up until now, we sometimes have few isolates that are susceptible to trimethoprim sulfa, and we use that whenever we can. But for the majority of cases, we're limited to these two drugs. We have been able to obtain cefiderocol. In few cases, the patient had to purchase them from abroad, but none of the other newer drugs are available to us. I would say the mortality of patients in my hospital who have Acinetobacter, either bacteremia or pneumonia, or even the skin and soft tissue infections following war injuries is over 65%. So this remains a big, big challenge for us.
Yeah, it was really interesting to see the IDSA 2024 guidance, where now for the first time, sulbactam, durlobactam plus a carbapenem was their preferred choice for treatment of carbapenem-resistant Acinetobacter. Now, sulbactam, durlobactam is only available in the US, and I think it's just been approved in China, not available in Europe, Latin America, most of Asia. But it acts on the principle that sulbactam actually really nicely binds to penicillin binding proteins of Acinetobacter. So we always think, oh, sulbactam's a beta-lactamase inhibitor. With Acinetobacter, it also acts like a beta-lactam. It binds to the penicillin binding proteins, but also it can be broken down by beta-lactamases. And this durlobactam, which is this new beta-lactamase inhibitor, inhibits even the OXA20 and OXA24 of Acinetobacter. If people do have it available, I'd recommend that they read the pivotal randomized trial because there were some outcome differences with it. There is a really interesting new antibiotic called a potentiator of antibiotics called zidibactam, which is in phase 3 trials at the moment. And the combination of cefepime and zidibactam looks quite interesting for Acinetobacter. Rifabutin, which we remember from, MAC days, there's an intravenous formulation of rifabutin which is synergistic with cefiderocol or polymyxins and has really interesting activity against Acinetobacter, also in clinical trials. There's a new one called zosurabalpin, which is a novel class of antibiotics, macrocyclic peptide specific to Acinetobacter, which is about to start in phase 3 trials. There are non-toxic polymyxins coming. So hopefully we will have some options for Acinetobacter. The real shame, though, is that the parts of the world with the biggest burden probably will never see these new drugs unless something really innovative comes in terms of access to these antibiotics.
I agree that the underlying problem here is really access all around the world. These bacteria are everywhere.
There are some organizations, such as GARDP, for example, who are trying to make the novel drugs available in low middle income countries, but under controlled environment. There is one publication where we work together with them on how can you bring such novel drugs to countries that needs them the most, but cannot afford paying for such drugs. You can create an alternative model to really help with this.
GARDP is based here in Geneva, and they are doing amazing work. They're very, if I'm up to date, still quite well supported by other big institutions, notably WHO, of course. And Thomas, I think you're working with GARDP as well, correct?
Yes, we were having a theme issue in CMI in October about this. So it's about availability to new drugs, but also old drugs, and how to introduce the new antibiotics we get on the market responsibly. So as we come to a close, David and Souha, what are the key messages you'd like to leave our listeners with?
So for me, number one is diagnosis. Without collecting appropriate cultures, we'll never know if there's a carbapenem-resistant organism, and then we'll be left in this empiric state forever. And number two is really understanding that with carbapenemases, there is not one antibiotic that fits everyone, and that understanding carbapenemase allows us to really get the most appropriate antibiotics for our patients. So there's some of the big treatment principles from my viewpoint.
Yeah, I fully agree with David. One very important point that I would add to that is you need to know, as a healthcare provider, your local epidemiology, because that will allow you to really think about what would be the optimal empirical therapy, particularly when you're faced with a very sick patient. Many studies have shown that delaying proper therapy for even 12 to 24 hours can really affect your morbidity and mortality. The second issue is diagnostic stewardship. We talk a lot about antimicrobial stewardship. You want to pick the right drug for the right patient, for the right duration. You want to avoid combination therapy whenever it's not needed. For example, if I'm using some of the novel beta-lactam, beta-lactamase inhibitors for CRE, studies have shown that there is no point in adding polymyxin, for example, to ceftazidime avibactam for treating KBC. It does not improve survival. All it does is it adds to the cost and the toxicity to the patient. But also, we really need to consider the diagnostic stewardship. David talked about using the right tools to diagnose your infections, proper specimen collection, etc. But think about what cultures need to be collected for the patient. If I have a patient who's coming with obvious pneumonia and they have a catheterized bladder, but they don't have any urinary symptoms, and clearly they have a focus of infection in the lungs, let's focus on the lungs. If we do a lot of cultures from everywhere, we're going to be finding a lot of bacteria everywhere, and this will lead to a lot of overuse and abuse of antibiotics. So I think in addition to antimicrobial stewardship, diagnostic stewardship should be applied to every patient we deal with. The last point is, in the past, there was this thinking that novel drugs should be left on the shelves because they are expensive, they are novel, we don't want to overuse them and lead to resistance down the road, but that's not proper stewardship. Again, I think the novel drugs, if they are available to us and if they are the best choice to treat our patients, we should really select those to treat our patients. And last but not least, really, we need to be talking to each other. We need to be talking to the intensivist, hematologist, to the microbiologist. I think the multidisciplinary approach to the proper use of antibiotics apply to infections in general. The CRE management can be even tougher to deal with, and that's why we need to be really addressing this at the multidisciplinary level and talk to each other.
Thank you so much, David Paterson and Souha Kanj. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Thomas Tängdén and Angela Huttner, editors at CMI Comms, ESCMID's open access journal. It was edited by Dr. Katie Hostetler-Oy and peer-reviewed by Dr. Filippo Medioli of Azienda Ospedaliero Universitaria Policlinico di Modena Infectious Disease Unit. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks, and any literature we've discussed today can be found in the show notes. Our next installment of the Nightmare series will deal with vancomycin-resistant enterococci. You can subscribe to Communicable on Spotify, Apple, wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.